Imagine, if you will, a trauma bay where a patient who was just shot in the chest has been resuscitated, and you see what looks like organized chaos. You see blood on the floor, sometimes a lot of blood. You see instruments, bloody instruments. You might see a nurse that's crying.
Of course, right.
And of course, family members. And I think that organized chaos is where people who know what they're doing earn their keep.
How do you take control of the room and your mind when it counts?
I will answer that question, but I'm going to say something that you're not even aware of. Are you ready? You're sitting down?
In this episode of the Strongling podcast, we enter the trauma bay, where leadership, composure, and decision-making collide under the harshest pressure. Dr. Joe Nemeth is an emergency physician, trauma team leader, and associate professor at McGill University. He's led countless life and death moments at the Montreal General and Children's Hospitals, while building the training systems that prepare others to do the same. We explore what it takes to stay clear when seconds decide survival, how leaders take control of chaos without losing focus, how teams manage cognitive load under uncertainty, and what medicine teaches us about resilience, adaptability, and trust when every move matters. This is an inside look at performance under pressure through the eyes of someone who's lived it. Before we dive in, don't forget to like and subscribe to keep learning from the experts who keep us sharp, resilient, and ready when it counts. Dr. Joe Nemeth, it's a genuine pleasure to have you here on the Strongling podcast. I'm very much looking forward to jumping into this talk together.
So am I, big time. Let's
Amazing.
go for it.
Fantastic. So I'd like to start here. In trauma care, every second, every decision can change an outcome. How do you take control of the room and your mind when it counts?
I will answer that question, but this is all impromptu. I'm going to say something that you're not even aware of.
Amazing. Let's do it.
Are you ready? You're sitting down?
I'm primed.
Sounds good.
Let's do it.
So listen, I'd like to give 2 kudos to you.
Oh, amazing.
I think I'm speaking for the medical field. We're very easy, very quick to critique, but very slow to congratulate and pat people in the back. I think you've interviewed, and in your experience too, I'm pretty sure it's the same with the people you've interviewed. For some reason, high achievers do not like to congratulate others. There are some exceptions, but I'd like to do that now.
I appreciate
on two counts. Number one, I've looked at all your product, what you put out here, and it's incredible. I think it's very useful for people in my sphere, but in any other industry, and frankly, even a stay-at-home mom, just to talk about the importance of how you manage stress and cognitive load, and get different perspectives. So I applaud you for that.
Appreciate that.
And on the second note, I applaud you for getting a little bit out of your comfort zone in that you picked me. Somebody who is not in the business field, is not in the military field, and I think that's going out of your way a little bit, and you're taking a chance, and I appreciate that. But I'm pretty sure I have a lot to offer.
Absolutely, and I thank you very much. And you're absolutely right. Taking that moment to step back is something that we always seem to miss in the high-performance world. But I think it also speaks to that earned wisdom that you bring to the plate, and I can't wait to unpack that.
Perfect. And before I answer your question, I think it also helps with cognitive load and how to minimize and mitigate the stresses, meaning somebody who's supportive and who pats you on the back, that helps. But we'll talk about this later.
Sure, yeah.
So imagine, if you will, a trauma bay, or we call it a recess bay or trauma room, where a patient who was just shot in the chest has been resuscitated for 10, 20, 30 minutes, 60 minutes. And the room is empty now. And you see what looks like organized chaos. You see blood on the floor, sometimes a lot of blood.
Right.
You see instruments, bloody instruments. You might see a nurse that's crying.
Of course, right.
And of course, family members. And I think that sort of, that organized chaos is where people who know what they're doing earn their keep. So how to take control of a room, we'll probably talk about that and nuance that a little bit later. But really, for me, it's organizing yourself first, your team, your environment. And how you do that, there are different strategies which we will discuss, but really it all falls under the umbrella of crisis resource management, which I'm pretty sure you're aware of. It comes from the aviation field, and of course, the military uses as well. Actually, that CRM sort of acronym is really crew resource management, but we took it over to crisis resource management. And the whole idea of this is there are many levels, but the whole idea here is that you role delegate, you anticipate problems that might arise. You walk that fine line between sort of directive leadership and empowering leadership, and we'll talk about that in a few minutes, what that means. Communication, confidence, tone, mannerisms, how you stand, incredibly important.
Okay.
And then we can talk an hour about communication styles of closed loop and how you close that loop when you ask for something or you want something to be done, how that is done. And we'll talk about that later. Also, in this chaos, organized chaos, regularly sharing your shared mental model of where things are at with the patient and where we're going with it. Delegating tasks, creating micro teams so that you as the team leader are not overwhelmed. And reminding yourself in this organized chaos is you can not afford to take your foot off the pedal, because trauma is a dynamic entity. It's not a neurosurgeon, God bless them, but standing over a patient for 10 hours. I could never do that. Trauma is a dynamic process where a patient can come in walking and talking to you and in a minute be in cardiac arrest. And keeping that in mind, you have to make the decision. So that's sort of how I see, taking control of that organized chaos.
Okay, so a lot to unpack, but I think you brought up something really interesting that resonated with me, and I'd like to kind of take a step back and ask you about this. So this tie to aviation, the crew resource management model, a derivative of the human factors piece. And I remember this was a science that came out of NASA really in the 70s, once we were looking at the accident and incident rate in aviation and how it wasn't reducing at a certain point. And they had seen that the technology had kind of gotten to a pretty safe point. So it wasn't the technological component, but it was the human component. And I'm wondering, when we're looking at crisis resource management and how you've seen it kind of evolve over the past few years, are you seeing the same kind of effect? It was at some point an indicator where we need to look at those micro teams, very similar to a pilot co-pilot engagement or a fire team within the military. And I'm curious about that context. When did this focus on the human crisis resource management really come to the light? What would you say?
I'll answer you in a second, but if I could nuance your description that it comes from NASA, I would argue it comes from the Canary Islands.
Interesting.
And I'll explain to you what I mean. The biggest aviation disaster happened in one of the islands in the Canary Islands in the late 70s. 2 jumbo jets collided, and I think there was over 500 people who died. And I think it still goes down as the biggest aviation disaster.
Was that the one on the runway?
That's correct. That's correct. Absolutely. That's correct. For those that don't know, you should take a look at it. There's many videos on this. And I completely agree with you that up until there, people were looking at the wrong thing. When planes were crashing, they were looking at the technology. But where this incident happened, they actually looked at the fact of human factors, and they identified that this could have been all avoided if the pilots and the tower communicated properly. There was absolutely horrible communication, closed loop. There was nothing, checklist. And because of that disaster, the aviation industry looked at how they can mitigate these potential errors. And if you look at the chart of how, from that point on, how the incidence of crashes decreased exponentially. And I think it all has to do with the fact that this is looking at human factors. Now, with regards to your question in my domain, what do you think the error rate is in the emergency department, and by error rate, I mean a misdiagnosis. Do you think
Sure.
it's 50-50? Well, I guess it depends on the physician,
Well,
but
there's a-
is it 25%? Is it
Sure.
like less than 1%? What do you think the error rate is?
So I would say, and this is me as a potential patient, and where I would hope the system is. I want to hope it's within single digits or less, or percentage of a percent, ideally. That
Yeah.
would be my hope.
So it's about 10 to 15%.
Okay.
Now, when we started looking at that, and initially we didn't look at it the right way. So in the aviation industry, if a plane crashes, the question is what happened? In our industry, up until recently, if a patient died, we have what's called morbidity and mortality rounds, where the physician is put on the spot like this.
Okay.
I mean, I'm dramatizing it a little bit, but really it's a finger pointing exercise. And that's the wrong way to look at it. So in our field, it was like, what did the physician do wrong, as opposed to, let's look at this systematically.
And that's what's currently taking place.
Yes. It's so getting back to the error rate, that 15%, we looked at that, and there's some good literature on this, that the majority of the errors are not made because of lack of knowledge. Like, people, if you look at literature on who gets sued and what are the reasons there's there's litigation against the physician, it's rare. I'm not saying it never happens. It's really because the physician did not know that this drug was needed for this. It was more of communication, how they process information, very closely tied to cognitive load.
Right.
And if they're overloaded, their decision-making capability disintegrates, and we'll talk about that later. So that's how we look at it.
Wow. So you're saying the contribution of cognitive load, and 15% is not a small number, especially when we're talking, this is a mortality, not a mortality rate.
Diagnosing error. Right?
Diagnosing error rate. So, and of course, every error in diagnosing is going to trigger another cycle, another decision action cycle.
It could.
So that's even a bit more wasted time that could go into resolving the situation. So what we were saying is, you're looking at the human component, the cognitive decision making. Would you say that that's the main outcome? That's really the contributing factor?
Absolutely. Okay. And that is influenced by many stressors. Whether it's what you bring into your shift, that means at home.
Right.
And we will talk about mindfulness and peace and contentment. That's so incredibly important. And all the stressors that are I was going to say intuitive, not intuitive, but interior to the room. So the patient brings in their whole set of complexities.
Right.
A patient can come in with an itchy scalp, and it could be something horrible, right? So we always we're always on edge as to what this seemingly easy case could become very, very difficult. So yes, so this cognitive load that you bring in, definitely, and there's great psychological literature on this,
right.
that it definitely influences your decision-making activity. If I may, the marketing industry takes advantage of this. I'll give you an example. So when you go to the, I'm not going to mention whatever grocery store.
Sure.
Can I swear here or no? Bullshit?
You know what? I'm not sure.
Bullshit?
Go for it. Let's just do it. Let's go for it. Yeah.
So when you get to the counter or to pay, the bullshit is there. Meaning what? The stupid newspapers, National Enquirer, it used to be at least, the candy, the gum.
Right.
The whole idea here is that they've cognitively loaded you already when you walk through the aisles. 100 million cereal boxes, this kind of milk, that kind of cheese. You're coming to the end to pay, and you're cognitively overloaded. And whether you admit or not, your decision-making ability has gone down the drain.
Sure.
And a lot of people would push back on that, but there's great literature on this. And so they know this. And so if they would have put those stupid things in the front, you're walking past them. You're not going to buy the candy bar. You're not going to buy National Enquirer.
Right.
But here, you will. And that's an example of how cognitive load weighs in on how you make decisions. Now imagine that in treating you with chest pain.
Right. And if I were to, that specific mechanism, that point, cognitive load is exhausted. You go into the grocery store, you're getting to the end. What is the condition that's making me choose that sugary treat at that point versus in the beginning? Is it, I'm just looking to reduce the stress from the cognitive load? I'm looking for a quick fix?
No. I don't think it has anything to do with the fact that I'm hypoglycemic, low blood sugar, because you're not. You're not. It's more that you have in front of you decisions you have to make, buy or not buy, and what am I buying? And now that part of your brain that usually manages this is overloaded.
Okay.
And there's some great. I'll give you another example of who takes it. A couple of studies that looked at this. So they looked at a parole board.
Okay.
And they looked at prisoners that are going up for parole, and they want to be set free, right? So the parole board meets with them, and they looked at decisions of the parole boards that if you, as a prisoner, come in for a parole meeting in the beginning of the day, you're more likely to be let loose than if you come at the end. Why? The thinking is that by the end, the parole members cognitively overloaded. They are done. And for them, the default is no. Right. And so there's that. And there's some evidence for that very briefly in medicine as well. Many, but I'll give you an example. They looked at a bunch of family physicians who saw patients, and the patient came in with a viral illness, a runny nose, cough.
Sure.
And if they came in earlier on, they will not get antibiotics. The physician will take time and explain that you don't need this antibiotic, sir. But if they came in at the end of the day, much more likely to get an antibiotic. So these are examples of how cognitive load weighs in on your decision.
Yeah,
Does that make sense?
Yeah, absolutely. As you're talking, it's reminding me of examples even in aerospace, shift work, so making these critical decisions in the afternoon or evening shift, or even just the military side of things when you're operating at night, purposely pushing through sleep. So I can't wait to dive into that. If I take a second first for you and your story, what I'd really like to do is take a second and ask you, what first drew you into emergency medicine, trauma leadership, and what keeps you there? You're very energetic and clearly passionate about the topic. So I'd like to know the why behind that and where that started.
I'll premise my answer with a couple of things, and I think credibility is big, right? So why should anybody on this podcast listen to me, or even take my advice, or take not my advice, but what I say? Look, I have 28 years of emergency medicine experience, and I'd broken this down. I did this mental exercise recently, so that equates to approximately almost 7,000 shifts of 8 to 10 hours, and that equates to approximately 160,000 patients that I've seen. Okay? So approximately.
Sure, of course.
So I have a little bit of experience. So that's number one. So getting back to your question, why emergency medicine? So there's a sort of an algorithm, a flowchart of sorts for medical students to decide what they want to do. It's a little bit facetious, but it sort of makes sense. So in the top you have medical student. Are you crazy or are you sane?
Okay.
If you're crazy, you're going to go either into emergency medicine or psychiatry.
Okay.
And then when you say you're crazy, do you have an attention span? If you don't, it's emergency medicine. If you have an attention span, it's psychiatry.
Okay.
So that sort of gives you an idea.
So this is mapping well with you.
It's perfect.
Okay.
If you talk to my wife, if she was right here, she would say the same thing. He's crazy and he has no attention span.
Okay.
All right. So I think when a medical student asks me, like, should I go into emergency medicine or not? What I tell them is, you definitely need emotional EQ. You need EQ.
Okay.
So if you're one that is very you compartmentalize things, and this is this, then I'm going to go into that. That doesn't work in emergency medicine. So you might see in 1 minute, you might see a patient who has an itchy scalp for 5 years, and you have to explain to them that it's probably not an emergency. And in the next minute, you might have to tell a wife that her husband was killed by a car, and so you need that EQ, right?
Absolutely.
And I don't think other disciplines, and I don't want to minimize, and I don't disrespect other disciplines, but to the extent that we need it, I think it's pretty significant,
yeah,
right?
Absolutely.
We need to be inventive, efficient with our time and our efforts. We need to be energetic, of course, friendly, confident, but not in extreme cases, because if you're overly confident, you get very dangerous.
Right.
If you're too cautious, that makes you a horrible emergency medicine physician as well, because you need to be able to move people, get a disposition on people. So a patient comes in, I have a certain time frame to make sure they're not dying, and then I have a certain time frame to make sure that they get the right treatment by the right physician and get them out of my department as soon as possible, if needed.
Right.
So you need to have both of those things. Now, that's emergency medicine. Why trauma? Well, trauma just takes it to another level.
Actually, for the viewers, how would you define emergency medicine and trauma? What distinguishes those two?
It looks like you're reading because exactly
okay.
I was gonna explain to you. So, just for people who don't know, the field of emergency medicine means that you're taking care of patients coming in with an acute injury or illness. So that could be a gunshot to the head, or it could be a heart attack, or it could be an itchy scalp. So what happens now is that our field has become very super specialized in that there's under emergency medicine there are different subspecialties, and one of them is trauma. That doesn't mean that a general emergency medicine physician cannot take care of a trauma patient, but there are now people who have trained and are passionate about trauma that take it to another level, and they're called trauma team leaders. In fact, I will proudly say that we developed in McGill the first trauma team leader paradigm, as it were, in 2005. And the whole idea here is that in the field of trauma surgeons ruled. So the surgeons ruled with the resuscitation, and of course, when the patient goes up to get surgery, it's the trauma surgeon that deals with that. This whole trauma team leader paradigm started by saying, listen, emerge docs with special training can resuscitate the patient, meaning the acute care issues of taking care of so the patient doesn't die in the first 15, 20 minutes, 30 minutes. We can do the same as surgeons. And so that's what I mean by a trauma doctor as such. So I'm one of the trauma team leaders that takes care of these kind of things. Is that clear?
That's clear. Yeah, that clarifies it.
And so, and then what keeps me there is that that desire, and I think I speak for most of my colleagues, that desire to make an immediate impact and significant impact on a patient's status, especially if they come in very ill. The variety, the fast-paced nature of our business, unpredictability, the environment that's oftentimes very chaotic, and the blend of all those things. Teamwork, you need to be a team player. So all of those things, I think, if you were to, if I were to line up 10 of my colleagues, they would say the same thing. These would be the things that keep us there and then make us love what we do.
Okay, I keep thinking of three words when I was listening to that description. It seems like the effect you're looking to scale and enable consistently is that capable, adaptable, and ready team to manage those different environments.
Exactly.
And that's a state of readiness, that takes effort and testing and retesting and revalidation. So it certainly seems like a huge undertaking, to be honest.
Yes.
It speaks to that earned wisdom. So I'd like to pull on that. How do you define performance under pressure after a decade of leading these trauma teams?
This too we could talk about for a long time, but really the ability to maintain situational awareness, where you know when to step back and wait versus when to act right away, prioritizing life-threatening issues and decisively executing that plan. Once again, a continuous shared mental model, incredibly important, so that the team around you who is looking to you for team leadership understand where your mind is at with the case, and what as a team leader's concerns are in the next few minutes. So that shared mental model that has to be almost seamless and continuous and not intuitive. So not thought that it's everybody's aware. You have to make that a conscious and active effort to share that. Clear communication, role clarity is incredibly important, and you'll see, I think, I'm going to say it often, that communication is so important, that closed loop communication. Maybe I'll take a little bit of time to explain what that means is. So if if I have a patient who is actively dying in front of me and they have a heart attack, and I tell nurse A, if I say, can someone give this patient this medication? That is horrible communication skills, because someone is no one.
Sure, not precise enough.
Someone is no one. And this brings up the whole idea of the aviation industry as well. And if you look at that video of those two planes crashing, a lot of it was this, right? So what should happen is the following. Nurse A, call her by her name or whatever, can you please give this medication? Once you give it, please let me know. So it's not a question of only telling her do it, but telling her to feed it back to me that it's done.
Right.
Incredibly important. And it seems very minimal and nuanced, but it's an incredibly important nuance. So that's what closed loop communication means, and that's part of performing under pressure. Another thing that's very important in performing under pressure is avoiding tunnel vision, and that's why the team leader has to be as hands-off as possible of the patient. So as a trauma team leader, I'm able to do all of the procedures that need to be done. Like, just to give me an example, we sometimes are called to open up a chest to arrest a bleeding from a heart that's been punctured by a missile, whatever. And so we're called to fairly high level of procedures, but we as team leaders should never do that. We should have the whole picture in mind, the forest, not just the tree. And if you start getting involved in somebody's procedures, you get tunnel vision, because that's all you're seeing. So a good person who performs under pressure is one that does not fall into that cognitive error of tunnel vision. Staying calm, thinking ahead with contingency plans, and adapting to shifting priorities. I think these are the main things that are important.
Yeah, so I pulled a lot from that. And I really liked the closed loop approach and trying to avoid that tunnel vision. Can you take a second to expand on what you mean by an explicit mental model that's shared collectively with the team?
Yeah, so what we say is every 5, take 5. So what that means is that not necessarily 5 minutes, but on a regular basis during a resuscitation, you should take an amount of time to share what's happening. So what we usually say is that patient comes in early on, you do the initial potential reversible life condition threatening issues, and you deal with them, and then you stop. Okay, so let's see what we have now. So patient came in with XYZ. This is what we did. Now we're going on. Potentially this could happen, this could happen. Then we do another set of resuscitation measures, then we stop again. There's no time set. There's nobody counting on a clock. Okay, Joe, it's another 5 minutes you have to take. It's also intuitive for a good leader to know when to make those stops and share explicitly with their team members what I'm thinking of and where we're going.
Oh, so that's really interesting. So in this situation, which is a crisis moment, and you're dealing with it, pumping the brakes or taking a short pause at the right moment, but collectively speaking out loud, okay, this is the current state, this is what we see, what are some options, okay, let's keep going. And then actively introducing those pauses in that crisis act state.
If I could interject one more thing with these pauses, and I make this very explicit before the patient comes in, is that, number one, I make mistakes. So during those pauses, I will say often, okay, guys, am I missing anything?
Okay.
Incredibly important, and to empower your team, not to feel intimidated that here's the, high and mighty. No, that's number one. And number two, to give you an example, what I mean by that is that I empower the team if they see something that's critical to interject at any time.
Right.
So we have a sort of a call out thing saying critical finding. And I have no problems with even a med student. I was going to say a lowly med student. I was a lowly med student, so I can say it. But anybody in the team saying critical finding, and I'll stop.
Okay.
And of course it's understood. It's not critical finding that the patient's shoes are undone, right? It's something. So these are just examples of how you have to stay humble, empower your team to feed things back to you, whether it's on a regular basis or at any critical time.
It's really sticks out to me. I was introduced to immediate actions and these immediate reactions you'll do when you're under fire or dealing with a situation within the military. And we have our communication drills and everyone's doing their particular actions. But to hear, and it is comforting, to be honest, these check and balances happening in real time with members who may see a critical failure point and be able to be empowered to interject, and that constant reevaluation, realignment during a critical state. Because I've seen it, I've rehearsed it, where you can be triggered with an immediate action and you can immediately derail and get into the wrong course of action. So this is really interesting to pull from that. You've spoken about cognitive load or adaptive cognitive load. What does that mean, especially for someone who's never really heard that term? And how does it affect decision making when time and clarity are limited?
Sure. I think before we talk about adaptive sort of cognitive load or how you do that, so what is cognitive load? It's the amount of sort of working memory or knowledge base that you have at any one time that is available for you're using. I think that's the best way I can sort of explain it. Is that at any one point when you have to make a decision based on your experience and your knowledge of that situation, you have to make a decision. That's your cognitive load there. Really, it's what it is, Ashan, is to maximize signal to noise ratio. So signal is the pertinent positives and negatives of a case, and noise is everything that's not. And a good clinician, and I'm not saying just a trauma doctor, but an emerge doc, and I've stressed this to the trainees, is that if you can weed out the noise, you're that much better. So when a med student asks me, well, Dr. Nemeth, what's a noise? Well, noise is patient's favorite color. I really don't care about that. I'm just using it as a facetious example.
Of course.
But noise is things that are not contextual. And if you can maximize that signal, which is the pertinent positives, and the noise, that ratio, that's better physician you are. So the way I think of adaptive cognitive load is, are you a Trekkie? Star Trek?
Of course, absolutely.
It was a rhetorical question. I knew you were.
Of course.
So, but the old ones, the real ones.
Okay. Of course.
So, Spock?
Yeah.
Kirk. So for those of you that we should watch a couple of series. Phenomenal. That it broke so many barriers.
Absolutely.
Incredible. I don't remember who the director was. Incredible.
Right.
Anyways, so the whole idea here is that I think that's a beautiful example of adaptive cognitive load, where Kirk is off the cuff, what we call heuristic thinking, experience, pattern recognition, not thinking. Not thinking. Thinking, but not thinking.
Sure.
And then, of course, if you know the series, Spock is that analytical, very thought-out person.
Right.
In emergency medicine, the extremes of both are dangerous. A good emerge doc walks that fine line. Do you play chess?
I do.
Okay. So if I tell you Garry Kasparov, does that ring a bell?
No,
okay.
Actually.
So it's before your time.
Sure.
He was a grandmaster look him up, 30 years. And I give a talk on this many platforms, and I put a picture of him up where he's playing simultaneously 30 different games with 30 chess masters, and he has like a minute to go from one to another, and then comes back. And I think that's a beautiful example of systems one, of this fast thinking and this slow thinking. And I was going to say system one, systems two. It's just another way of saying this different ways of thinking. So systems one is the fast, off the cuff, experience generated knowledge, and systems two is like the Spock, which is very analytical. So this guy goes from one checkboard to another and is using his experience to make fairly quick decisions, but yes, he's still analytical. I think that's the best way to think of adaptive cognitive load. Does that make sense?
It does, and it's interesting because it resonates with another speaker we had, Brian. He was a U.S. Ranger, and he talked about this ability where you need to be able, it's a muscle too, but he talks about selective focus, right? If you're doing a particular operation or you're at work or you're coming home, that it was highly beneficial to have this muscle where you selectively focus and then move on. So it seems a very similar approach to what you're talking to. Yeah. And we talked about the adaptive cognitive load. I really like this signal to noise ratio, and that's a skill. That's an ability. It's probably a learned ability with experience. I wanted to ask you about bandwidth. So let's however it's defined and measured, but is it possible to even increase our bandwidth when it comes to cognitive load so we can take on more and then be better at that signal-noise ratio piece?
After every question, I always want to say, great question,
Sure.
but I'm not going to because it's just going to sound, but this is another great question.
Sounds good.
So, yes, the answer is yes. And I think this goes back to signal to noise. I think you can increase your bandwidth for important things in what you're doing, high stress things, if you learn to minimize the noise. And there are many techniques to do this. You can delegate tasks. You can form micro teams to take care of stuff so you don't have to worry about that. And we'll talk about this, I think, later. But the way you use breathing techniques and how you self-talk and certain things that how you do within yourself, how you prepare yourself. Of course, knowing your stuff is incredibly important. Like we can talk about this all I want, but if I have no idea or I have very little knowledge of how to take care of a patient, this is nice, right? It's the classic Mike Tyson who says, we all have a plan until you're punched in the face, right? The same thing here. This sounds beautiful, but if you have no idea how to take care of a heart attack or somebody, whatever, pick your poison, then this is just BS, right? So knowing your stuff is very important. So that's sort of how I handle or increase my bandwidth, as it were.
Okay.
Is that okay?
It does. And we're talking about self-development skills. We're talking about honing it. And I think it builds into the work you're doing at McGill. For example, you've built simulation and fellowship programs at McGill. How do you design that training which replicates the mental chaos that we're speaking about that we find in real emergencies?
So I think once again, I'm going to bring this up again, but that the aviation industry has given us. We stole everything from the aviation industry in medicine. In fact, if you look at simulation medicine, who has really taken a forefront in this is the anesthesia world. The anesthetists have done a great job. If you look at literature, a lot of the literature comes from anesthesia about simulation medicine. I'm not quite sure why, but it is. So Emerge is lagging behind, but we are. So what we do is we especially in Emerge, we try to create simulation where we replicate that mental chaos of real emergencies or trauma, right? So that could involve using high fidelity scenarios, so using very high fidelity mannequins that can give feedback to you. There's even virtual reality now that you can use, and AI as well, and artificial reality as well that mimic the unpredictability of a physiology of a patient that's very sick. There's the other thing we introduce in these kind of simulations is controlled distractions. So we have alarms that go off out of the blue. Multitasking demands. Unexpected family member runs in and we have actually these simulated patients that are actually actors that come in and are trained for this, and they simulate that whole drama. And this is how we try. We train our trainees with that. Team dynamics, we definitely try to have simulations where there's interprofessional involvement. So it's not just physicians training physicians. There are nurses, different healthcare providers that are in this team, and that also simulates reality as well. And then stress inoculation. This we took from the military. And I think you know this much more than I do. I put this slide up as well when I give this talk is look at Navy SEALs, right? Navy SEALs, for those that don't know, are very high-level Army military personnel that do very high-level, high-stress things. And it's a whole nother level of military expertise and so on and so forth. And they stress inoculate them. And once again, preaching to the converted. I know you know this more, but I'm just more for the audience. That, for example, they make them do a 3-kilometer swim in the ocean, and out of nowhere, every so often, they have no idea when, somebody comes out of the water and tries to drown them. Literally. So it's simulated. So they're trying to swim. They're trying to maintain their head above water in these waves, and all of a sudden, they don't know when somebody comes in and tries to, and they have to fight them away, push them away. There's other things they do where they wake them up at 3 a.m. out of the blue. They tie their hands and feet and they throw them into like 12 foot of water, and they have to be able to float or monitor their breathing so that they can stay float, they can come down and then push themselves up again, take breaths, and then do that. In the meantime, try to untie their knots and so on and so forth. So these are things that are incredible. And this builds, and we'll talk about this a little bit later, but this neuronal plasticity where your nerves and your circuitry are trained now to handle these things.
Right.
And then it becomes second nature. So this is what we try to introduce in our simulations as well. It used to be taboo to introduce death in simulation. Like you just nobody dies in simulation in emergency medicine. And I always thought that was wrong because that's not real life. So we're introducing death and it could be quite impactful, right? So these are the things that we can do. And of course, debriefing after a simulation is incredibly important, where we sit down with the trainees and we discuss what you feel good about, what you didn't feel good about, and we talk about not just the medical aspects, but the communication and so on and so forth.
Right. I mean, it really resonates. I mean, I've done the stress inoculation within the military, but to the medical field, and I think it speaks to the unique challenges that take place within medical simulation. We will do stress inoculation in different tactical training scenarios, but one of the toughest scenarios that we purposely try and train for are mass casualty situations or casualty evacuations. And it's really interesting. You talk to an infantry soldier training for reacting to fire or setting an ambush or reacting to an IED situation. There's a steps from A to Z and we can get through it, and it's challenging. You throw in mass casualties when you don't know what the patient's going to do, if you're going to make them worse, and you're trying to deal with the situation. It's a whole different set of challenges. So I can only appreciate from a cursory piece how difficult this must be in terms of what you're looking at enabling. So in terms of bringing this all together, when you come to the different systems in place, right? So what roles do, let's say, systems, checklists, which again is taken from the aviation piece as well, how does that go into protecting cognitive bandwidth? And I'd like to just frame this. There are leaders, I remember in my time in aerospace, who are dealing in those crisis situations, and their cognitive bandwidth is challenged, but they don't have the benefit of SOPs checklist. There's that gap. So how does this play a role?
So it's interesting that you bring this up, because we're actually, with one of my resuscitation fellows, we're working on what we call a Mayday checklist.
Oh, interesting. Okay.
So once again, we are copycats in medicine, and we started looking at checklists many years ago because the aviation industry worked. It cut down all the crashes, so it must work with us. So there's checklists for, like, surgeons have tons of checklists. Is this the right patient? Yes, check. Mrs. Smith. Is this an appendectomy? Yes, check. Is the patient that? So there's checklists like this.
Right.
But as you can appreciate, in a very dynamic trauma scenario or any sick patient, we don't have time for that. A pilot can sit down before the flight and do the checklist. But when it's Mayday, they need a different checklist. They cannot go through 5 pages.
Right.
So that was the whole concept of developing a Mayday checklist. And we're doing this for many presentations that are life-threatening. Really like a one-pager, and I would even say a half-pager, where, of course, you're assuming a certain level of competence for the physician. But if this comes in, then I look at it. So I'll give you an example. So we have cardiac assist devices that our patients are walking around with. They're waiting for our transplants. Okay. It's a very rare occurrence that they come in with very sick, but if it does, we have to know what to do. And this brings up a whole concept of halo presentations. I don't know if you ever heard of that concept.
I have not.
Not
no.
halo, halo, but halo. So high acuity, low occurrence. So halos are what emerge dogs live for. But we need, and getting back to your before question is the bandwidth, we need aids, because I'm not going to see this type of patient maybe once every 6 months.
Right.
But when they come in really sick and they're dying in front of me, like I don't have the knowledge right now to do, what do I do right now? I sort of have a knowledge, but I don't. So I have this Mayday checklist where, okay, I pull it out, this, and I know. So I know what's going on, but this reminds me of, these are the steps you have to take right now so the patient doesn't die. Once again, these are not for, don't think that emerge docs walk around with these Mayday checklists. It's for the truly halos, the high acuity, low occurrence. And it just gives you another cognitive offload. It's a cognitive offload where I know that I have in my pocket the Mayday checklist, and patient comes in with your run-of-the-mill stuff, so HAHOs, so high acuity, high occurrence, we don't care. But the high acuity, low occurrence ones is the ones that we need these Mayday checklists for. And that's how we mitigate that, and that's how we help each other and to cognitively offload.
Right. I really like these acronyms because it speaks to a challenge which I even faced myself, specifically on cognitive load. So HAHO, let's say. It's high, yeah, exactly.
High acuity,
Acuity.
high acuity, low occurrence, halo.
Halo.
Halos.
Low, so
and there's low acuity. I'll give you an example. Low acuity, low occurrence, dandruff for 5 years.
Sure.
I don't really care if
Sure.
I don't need a checklist for that.
Right,
Okay?
right.
So I'll give you an example of a high acuity, high occurrence, like somebody with chest pain or a headache. We don't need a checklist. An emerge doc is competent. That's why we're emerge docs. We don't need, okay, what do I have to do now, right? But I'll give you, this is one example of where we see something once every 3 or 4 shifts or 3 or 4 months. I think it's good that we have these kind of things.
Absolutely. So what I've found really interesting is checklists in the use of it can be paralyzing.
Yes, absolutely.
Exactly. And,
absolutely.
And I've lived it where I was like, so we had to do different scenario training and competitions and so on within the military. And I remember very early in my leadership career, I was given the opportunity to try out, lead these patrolling teams and go on. And I tried to come up with a checklist for every possible situation. And then
how long were your checklists?
Oh, I had pages and pages, right? And we would laminate them and everything. And I distinctly remember when I was given the opportunity to go on one of these scenario events, which was my first foray into a complex environment which I wasn't used to. So complexity was significant, and the checklists didn't work. And I had to resort back to some sort of default state. We executed, we made it through, but it was really interesting because we were working up to the main event, and we had the benefit and privilege of being coached by some senior members, reconnaissance members, snipers within one of our Reg Force battalions. And they saw the same effect. You know, someone who wants to do better and is trying to come up with solutions and checklists for every scenario. And they pulled us aside, put their hand on our shoulder and said, you can't plan for every eventuality, but what you can look at in those moments where you can't resort to that checklist, it always stuck with me, was always try and approach it where you first eliminate the threat so that it doesn't get worse. Exactly. You know, establish security and then start working the problem.
And that's exactly what the Mayday checklist is.
Right.
That's exactly what and when that 747 drops 20,000 feet, that's when they're not going to pull out 10 pages, right?
Exactly.
It's big, right?
And you're right, because even in aviation, it was drilled into me: aviate, navigate, and then pilot. Like it's there. But I like the distinction between high occurrence and low occurrence, because in those, you know, the low occurrence points and the high acuity, those critical moments, you need that checklist and to be able to rehearse those critical moments. So I think that's a really powerful takeaway. So building on these high stakes events, after a high stakes trauma event, what does recovery actually look like for you and your team? You talked about the EQ piece, right? Multiple spikes. There's a resilience component there I'd like to pull on.
Yeah, there is. There's some science behind it as well. So when you're faced with any stress, whether it be a stress of going into work for the first time, for anything, any stress, it obviously doesn't speak to just medicine, any stress at all. There's a sort of an incredibly well-established system that kicks in that helps you navigate and helps you think, for the most part, clearly, it's the sympathetic nervous system. And so the whole idea here is that whenever you're faced with any stress, there's a certain set of hormones that are released. And if it's not overreacting, because too much stress is no good either, obviously, it actually helps you to process information, be alert, and so on and so forth. So that's where your heart rate increases, your breathing goes a little bit faster. In fact, they had there's some literature showing that there's very optimal heart rates with stress.
Right.
And I think some of this is military.
I've seen some,
where if your heart rate goes above a certain amount, and this too is very subjective, right? Like both of us are in good shape. What's your resting heart rate? 50, probably.
I wish 50. I would say about 60, 64.
Okay, so let's say that you go up to 80. That's already fast for you. Versus my wife runs at 80. The average person runs at 80, right? So if you go up a little bit, and I'm not going to give you numbers because it's useless, your thinking process, your manual skills are improving. However, if you go too far, you start shaking, you start having tunnel vision, and that's not good either. So there's a whole idea of how I'm going to answer your question about recovery, but when that stress is gone, that patient, remember I gave you that case in the beginning where that patient, the room is empty now, blood on the floor, the patient, let's say, made it, that incredible sympathetic discharge, that those hormones now drop, and and that could be exhausting. That's why people are exhausted after something like this, and that needs to be mitigated. So getting back to more pragmatic answer to your question, if the patient didn't make it, I try to have a minute of silence. I think it's very important for closure. Whether you're a spiritual believing God or not makes no difference. I think that's important. I think a good debrief with the team, not an hour, but 5-10 minutes.
Sure.
So how do you guys feel? That's very important as well for closure. And I have a special one that I deal with the trainees, and the nurses actually have their own sort of debriefing. And then there's actually resources at the hospital that if you have problems dealing with this, the next day you have, you start having nightmares about the patient, you can actually call. So there's resources out there for you. And then last but not least, and definitely not least, is speaking to the family.
Oh, okay.
And that's part of after the fact, right? Now, I'm talking about if somebody doesn't make it, and that is a whole different level of stress and cognitive load, where you don't do much talking, you do a lot of listening, and if I continue talking, I'm going to have tears in my eyes because it happens. It doesn't happen every day, but it happens often enough that it definitely impacts what you do.
Is this something you can simulate? In the simulations you've done to stress inoculate, and I don't know if it's something that can be actually done in a scenario.
Yeah, like I mentioned to you, up until fairly recently, it was a taboo. Nobody dies in the simulation, right?
Right.
So, and I thought that was not good, right? So I think there are simulations where you don't go through the case, but the day of simulation is giving bad news, and so we talk about it, and then you go sit down but there's no case, right? Right. Takes away a little bit off the edge, right? So we tell people what's the strategy of going into a room, whether it's a room of parents of a 5-year-old that was just drowned versus whatever, right? A 90-year-old gentleman who is demented and end-stage cancer who dies. A little bit different dynamics of how you approach that, right? So we teach that, but I think we need to do a better job.
Yeah, it's really interesting because that is one of the aspects we don't dive into as much. We always think about those high energy, high stress states. But what about those low energy, high stress states when you're walking into a very uncomfortable decision? So really interesting. And this also speaks to doing that type of discussion in a fatigued state.
In a cognitively overloaded state, yes.
Absolutely. And so let's unpack that a bit more. What practices really help prevent this long-term cognitive fatigue or burnout in such an intense environment?
Yeah. So I like to think of it as cognitive capacity economics, okay? So a bit of psychology literature, and you might not believe this, but it's true. So every decision you make in life. So this morning, before 8 o'clock, you had to make a decision on what kind of coffee you're going to have. Are you going to brush your teeth before or after? What are you going to wear? What are you going to eat at supper time? So there's a whole set of decisions you make the first hour of life. By the way, you know how many decisions we make per day? About 20,000.
Wow.
The average person. And if you do the math, it's almost impossible because there's not many seconds in that.
Yeah,
so,
that's
right,
crazy.
right? So even if it's half true, but that's the literature. Incredible decisions. But you say, Joe, yeah, but I mean, what socks am I going to wear? I have to make a decision on these socks.
Sure.
So,
amazing choice.
I thank you. But that was a cognitive load. And you say, Joe, you really, no, I'm serious.
I believe it.
So the psychology words that every decision you make, even if it's incredibly small or you think it's small, takes away from your capacity for the whole day. When you wake up, you have a crap load of cognitive capacity.
Okay.
Every decision takes away from that. Every decision. I'll give you 3 examples. Not that they're idols of mine, or I respect them, but they're examples. So Obama, Steve Jobs, and Zuckerberg. If I tell you to picture them, Steve Jobs, what does he wear? Do you remember?
Black t-shirt, denim jeans.
Exactly. Zuckerberg
Similar.
and Obama supposedly always wear the same. They believed in this. So when they woke up, I don't want to decide what I'm going to wear.
Right.
Like they were firm believers in this. And I think more and more, and my wife and I have she knows this already. I drill it into her that like for me it's easy. I just wear scrubs, so I don't have to wear. But if let's say I had to like this. You told me come dressed appropriately.
Right.
I thought of this last night, not this morning. I said I knew already. So that's one less decision. So that's number one. So make sure that you're prioritizing your what you're thinking of. And then in your job, whatever your job is, you can always make you can sort of replenish your cognitive capacity. How? Eating and drinking. I'm a bad model at this. My kids will tell you that I drink a lot. Sorry, drink a lot.
Right.
But I don't eat. But you should. Humor, incredible. Way of it can improve that cognitive load and take away that cognitive overload. Cognitive R&R, cognitive rest and relaxation. Yes, outside of the job, you have that as well. So hobbies, travel, so on and so forth. But in the job as well, there's some good literature, and I tell this to all my trainees before a shift. Every 2 to 3 hours, I want you to do something for yourself. 5 minutes. Dr. Nemeth, there's maybe we should film this. There's so many patients to be seen. I said, I know. Of course, somebody dying in front of you, no. But 5 minutes is not going to kill anybody. And I would argue when you come back 5 minutes later, you're that much of a better physician because you've rebooted. So how does that look like? What can you do? I always say, can you give me some examples? They always say, eat, drink, and bathroom. I said, no, those are, of course you're going to do them. Do something else. Jumping jacks, meditate, pray. If you have a significant other, call them. I have 3 kids. I've been married 31 years. Every shift, I call my wife 3 or 4 times, and I text my kids once at least.
Wow.
Okay. These are cognitive offloads for me. It's not.
Right.
I didn't say this to pat myself in the back. I'm just telling you these are things you can do and you should do. So these are cognitive rest and relaxation events, and of course, inner peace and contentment and mindfulness. And for me. It starts with that. So my Christianity is very important to me, and that's where I take my inner peace from. That's the sort of number one, and then my family is my number 2 thing. So my relationship with my wife, it trumps everything. And if that's not going well, it's going to impact me 100%. People say no, it doesn't. It does. At least it impacts me. And of course, my kids. And then the rest falls into place.
Right. I was just scribbling these down like crazy. This is because it's refreshing to apply a framework or to take a look at what can be improved upon. So some of the parts that I found really resonate. So those decisions we make every single day. And I've felt it. You could be exhausted by the time you hit breakfast or that first coffee before you even show up at the first shift. And it reminded me of another term that I came across when we talk about this, which was to try to structure your day where you're translating the conscious into the unconscious. Like you said, you picked your outfit the day before, you're just going to now put it on, for example. So I thought that was very empowering. But the replenishment piece. So there's a concept where you're going to wake up, you get to work at whatever stage you're at, and you're going to grind through this. And you're missing so many of these opportunities to replenish, nourish, certainly, but the cognitive offload piece. There's this preconception that if you're in a high performance role, constant chronic stress, that you're not taking the time to spend time with the family, but multiple touch points with your wife and your kids throughout the day as a measure to cognitive offload and replenish as a sustainment approach. That's amazing to hear that that's even a possibility. So that really resonated. And that inner peace and contentment side. I can't think of the number of times you're in a high performance role, you're focused because you know the challenges that are going to come up in that shift. But you come back home and you may be unsettled because of how that day went. You were already pre-imagining what you needed to do to make it successful. Maybe you didn't hit that. And now you're in this distressed state. It's hard to sleep. It's hard to recover. Your mind keeps reliving it. So you're not really being able to dive in and gain that little bit of inner peace and contentment. So finding what that means to you, I think that's really highly resonating.
Can I interject there because
Please.
I wanted to just say that you said when I come home from a tough day, and once again, this is not just anybody. It's accessible to everybody. You need home to be an oasis. It has to be an oasis. For me, we have, my wife and I have two big chairs, and we call them our thrones, and the day starts there if I'm not working, and the day starts there in the morning, and the day ends there. So we sit down and we talk, and for me, coming home, and I'm not saying, it's always peach, it's beautiful all the time. Of course not. I live in the real world just like everybody else does, but for the most part, home for me is an oasis. And I think that's where you were headed, that you come home and maybe you didn't hit it all, you didn't you didn't hit it out of the ballpark, you didn't do this, you didn't do that, but you're coming home and what matters is your people around you love you, unconditionally love you, you're set.
Right. And
you're a king.
Yeah, it's amazing. And I think that's a really nice image. Despite the day, however it went, maybe if it doesn't fit what you thought it would be, but to know that you're going to come back home, you and your wife sitting on those chairs, those thrones, that is still going to be how your day ends.
And
right?
it sounds sappy, but it's the reason I say it like this is because it's not the fairy tale land. It's doable. It's doable.
And it's a cognitive offload activity.
It's a huge cognitive offload activity. And 5 minutes into my throne time with my wife, I don't even think about these things.
No, I can appreciate that. And I distinctly know that there's an inner tension that occurs when you're trying to grind through something and to convince yourself, take that moment, take that break, go call the wife. There's a reluctance, but once you do it, you can replenish yourself and then come back stronger.
Absolutely.
Really amazing. The bringing it back for high performers. So for high performers across multiple fields, and that's the intent of this podcast, this intent for high performers, from medicine to aerospace to defense, what simple habits help really build cognitive resilience, managing that mental load before overload, or that replenishment and restoring clarity under pressure? I know we've talked about quite a few of them, but if we were to
summarize,
those habits.
Yeah, exactly. I think I'll just summarize it because I think we hit on most of them. I think prioritization of your life. What's first, what's second, what's third, and that needs to be clear because you have to make sure you're prioritizing correctly. I think I'm old enough to say, and I have the right to say because I've lived a certain amount of years that the promotion, the financial stability is not what gets you. And it sounds sappy again, but it's the truth. Have you ever heard of a destination disease? Have you ever heard of that concept? So I think many of us in our field, high performers, and I think it's human nature that we look at the destination, promotion, a job, travel. I can't wait. I'm going to wherever, and you miss every day because you have the destination disease. You're going for that, and then when you get that, you're disappointed. Very brief,
Right.
a very good example is have you watched Chariots of Fire? That movie, recommended, Academy Award. So
Okay.
it's basically about a Christian runner who is running in the London Marathon, the 100-meter dash, and his stance against he's not going to run on Sunday. Regardless, that's not the point. The point is the following: is that he had a very good friend who was a better runner than him, and the night before. This is a true story. The night before the 100-meter dash, they're talking, and this friend of his says, I'm so scared about tomorrow. And the Christian friend says, why? I mean, you have this. I mean, you're going to win the race. You know that. He goes, that's what I'm afraid of, because I've done all this. I'm going to win, and then what?
And then what? Right.
Destination disease.
We've heard this with, I know we've come across this with Olympic athletes. Once you get there and you win, then what?
Look at Hollywood. I mean, you achieving everything, like you're famous, money, and you have a bunch of very, very, very unhappy people there. And I think that's destination disease.
Yeah, I think it's a very prominent factor, especially with high performers, because you're working towards that goal, that position.
You always have a goal, right?
Yeah.
And I know, I don't know you well, but I know you're the same way, for sure.
And you live, and what happens after that event? And it's a tough transition.
It's a downer. If that's your raison d'être, right? But if your raison d'être is something that will stay, then there's no downer.
No, I think it is a powerful transition point. I mean, even as a veteran, right? When veterans transition out, their goal was the military, and that defined who they were for a number of years. So when you get out, what happens next, right? And that's a significant challenge. And absolutely, so we've covered so much in terms of dealing with adaptive cognitive load, that bandwidth, so much to unpack here. And as we bring this to a close, what I'd like to do is pull on the science aspect and ask yourself, so how do you see the science of stress adaptation and cognitive performance evolving over the next decade?
Yeah, I think... like we discussed, these acute stresses bring about neurobiological sort of build new circuits in our brain, and they cause us to be more adaptive, enhancing our memory, and so on and so forth. However, the technology, what I could see coming down the pipes is, number one, for example, wearable sensors. So. I mean, this is very low tech, but I have a I have a smartwatch, and during these high stress events, I look at my pulse and I see how that is, and maybe things I can do. Maybe I should have done more deep breathing to bring it down a little bit. But there are a lot of other sensors that can come down where they monitor your heart rate. They monitor, the way you, maybe perspiration. I'm not sure, but there's definitely that's coming down, and using that data during high stress, maybe there's things you could do to mitigate how you deal with that.
Right.
AI-driven sort of brain fitness programs where instead of simulation medicine, you can help AI give you scenarios and work through those and help you to build that resiliency that will help. And I think these are the things that I could see coming down the pipe. Definitely AI is going to be a huge cognitive offload. We have to be careful how we use it, for sure. But I definitely see that being a big piece of the puzzle.
Okay. All right. Really interesting to see those trends come to fruition. Yeah, especially with the AI piece.
Yeah.
But we're building up some additional awareness that can ideally help build that cognitive bandwidth. Amazing. So, Joe, thank you so much for taking the time.
Thank you.
This has been an absolute pleasure. I'm going to be definitely knocking on your door. There's so much more to unpack here, and we need to.
My pleasure. My pleasure. It was a true pleasure, and it's a pleasure meeting you and spending some time with you.
Thanks again.
Thank you.